Hi, this is Marcy Swift talking on neurodynamics. In this clip, we're going to review the symptoms and signs that will point a physical therapist towards including neural flossing in their plan of care. Before we go to that, we'll review a little bit of terminology and historical background. Maitland just developed and described the slump test first, and then Elvey layered in the upper limb neurodynamic test 1. And then David Butler described variations of this standard upper limb neurodynamic test. All of those tests we will work through in this class. The next topic I want you to be familiar with are tension points. So these are points where there's no movement of the nervous system in relation to the interface tissues. So you can see these at C6, T6, L4, the posterior knee, and the anterior elbow. So an example of this is during the straight leg raise test in the slump position here. You can see the movement of the lumbosacral nerve roots are caudal in relation to their intervertebral foramen. And as they come down, the tibial nerve proximal to the knee is also moving caudal, that the neural system is moving caudal, but distal to the knee, it's moving cranially. And they meet these two opposing directions of pull meet at the posterior aspect of the knee, where the nerve interface relationship is constant during movement. So let's talk a little bit about the subjective exam findings that you might hear when you're interviewing your patient. The first part is the body chart, and when you're just taking in the information and locating the pain that the patient's describing and coming in with, they will complain of symptoms near the vulnerable anatomical site, which can include the entire limb. If it's an extraneural type impairment, they will complain of words like pulling like a tight string, catches of pain, and tightness. If it's an intraneural issue, the symptoms that the patient will report are something like bizarre clumps of pain, crawling, ant-like, dry, woody, and dragging, and report some sensations of swelling, burning, and electricity. The aggravating factors that the patient might complain of, specifically to the upper quarter, would be reaching for a seatbelt, repetitive movements that involve keyboarding, violin playing, phone in the crook of the neck, hammer overhead all day, different types of repetitive activities like that. In the lower quarter, they may complain of getting out of the car, taking a bath, kicking a football, or prolonged sitting, which may point to a slump type test that you would include. If they complain of an activity that includes anything with an extended leg, like walking or kicking, then you might include straight leg raise in your objective exam testing. And then if they complain of any activity in which the knee is bent toward the buttocks, such as hurdling, then the prone knee bend might be the test you consider in your exam. The ease factors for these patients is just being out of that tension position. The 24-hour pattern of someone with increased neural sensitivity is they oftentimes are worse at night, and so a lot of that has to do with posture. The symptoms may be worse in the morning due to the night position, and they may be worse at the end of the day, just that latent effect from sustained posture, repetitive activity. The history is next. The patients with upper quarter or lower quarter injuries may have a history of whiplash. They may have had surgery. They might have a history of trauma or some kind of predisposing occupation that requires repetitive activity. Specifically to the lower quarter, the patient's types of impairments that go along with neural sensitivity would be muscle strains, lateral knee and ankle pain, plantar fasciitis, Achilles tendinopathy, lateral ankle sprain, medial foot pain in conjunction with running activities, calcaneal pain, interdigital neuromas, and lumbar or thoracic radiculopathy. Moving on to the objective exam, things to look for in observation. You want to look for postures that fit with a neurodynamic dysfunction. So for the upper quarter, they may have a forward head, Their cervical spine might be in a little bit of lateral flexion, or they may have an elevated shoulder that almost looks kind of full through that upper trap region. In the lower quarter, when you're examining them and looking at their posture, look for a knee that's flexed and standing, and also look for a lateral shift. The active movements that you want to look at when you're having them go through the range of motion, look at the quality of movement with the testing and identify any kind of compensatory movements that they might be exhibiting during the test that might fit a neurodynamic kind of increased neural sensitivity type dysfunction. So for the upper quarter, it might be the neck is side bent with shoulder movements. For the lower quarter, you might see their knee bend when they're going through lumbar spine flexion. One thing you can do is add on to that observation or add on to that active movement by increasing tension. For example, adding a shoulder shrug with cervical spine flexion and seeing if that eases off the pain. And then for the lower quarter, when the patient's doing lumbar spine flexion, maybe add on neck flexion to see if that changes the pain, or also fiddle with the knee bent versus straight. Moving on to functional quick tests. So if you are suspecting increased neural sensitivity, you can put them in a position, a functional position that might increase the demand on their neural system and provoke their pain. In the lower quarter, some of these examples might be having them get in and out of a car or simulate that, have them actually kick a ball for straight leg raise, any kind of activity like gait or kicking. And as I mentioned before, any kind of activity that would require bending their knee, have them replicate whatever it is that is limiting them and pointing towards neural sensitivity. Try to replicate that in your functional quick test if their irritability is minimal. So how do you sequence the neurodynamic tests? Well, it's important to consider that because it helps to determine whether the problem is proximal or distal when combined with information from the OE of the non-neural tissues. So you may choose to change the order of adding components depending on your hypothesis. So the neurodynamic test is more sensitive if the examiner begins with the component that is closest to the symptom of complaint. Okay, so the next slide kind of gives some ideas of this. So somebody who is non-irritable, you can take up the component that is closest to the neural tract being implicated. So for the upper quarter patients, you would load the proximal components first, like the shoulder. For the elbow and wrist, if that's your primary area of pain, then you would load the distal components first. Okay. If the patient is irritable, then you would want to take up the component of the opposite end to the neural tract being implicated. So back to our examples of the neck and shoulder, you would load the distal components first because of the irritability of the patient. And likewise, with an upper quarter patient that has an elbow or wrist complaint, you would load the proximal components first as opposed to starting close to that area of the elbow and wrist. Documentation is sometimes difficult with neurodynamic testing, but it's important to be intentional about it in case a physical therapist follows you and is reading your notes. And so the way to do this is to document in the order of components added. Document the quality of movement with each added component, document the range of motion available, and document the symptom response with each added component. Some really just kind of general guidelines before you perform the test. Need to communicate with the patient. Need to test the asymptomatic side first. You need to know normal responses to each test and establish baseline neurological status. Want you to start in the same position every time you perform the test. Continually monitor symptoms. And then your assessment, again, what you're looking for while you're doing these tests is quantity, so the range of motion loss, the quality, and the symptom response. Let's talk about intervention. Before you select a neural flossing technique, go back to your framework, your worksheet. So step one is to, again, have that assessment at the forefront of your head. That's your filter, that's your working hypothesis that's leading you to including neural flossing into your plan of care. Step 2 is knowing the patient's end game. Step 3, make sure you run through your contraindications that we talked about in an earlier video clip for neurodynamics. And then once you've passed those 3 steps, you're ready to try to figure out the focus of your intervention. And a lot of times with increased neural sensitivity, you're looking at trying to reduce pain and increase mobility. So if your purpose and goal of including this into your treatment plan is to restore nervous system mobility and to normalize the sensitivity of the system. So the severity and irritability should be established prior to treatment. That's very important because neural flossing exercises can produce latent pain. So you want to have a really good handle on their irritability before you give out an exercise. And then also determine if it's an extraneural or intraneural or both. Communicate to the patient. That's very important. Refer to neurodynamic techniques as mobilization or flossing rather than stretching. For the non-irritable patient, you want to expect that you might exacerbate their symptoms, but that they should resolve in seconds. With an irritable patient, you don't want to reproduce or exacerbate any of their symptoms during the testing or treatment. So when do you add neural flossing? So you want to treat based on your examination findings. If you find a comparable sign with proximal tensioning, then treat with the proximal movement. If a comparable sign is achieved with distal tensioning, then treat with the distal movement. Here's an algorithm you can follow in terms of layering and progressing your interventions with manual therapy. It's best to treat the joint signs and soft tissue components first. Then you can treat the related soft tissues can be close to the site of the injury if it's non-irritable or further away from the site of injury if it's irritable. So again, start with joint signs and then move on to soft tissue signs, and then you layer in the neural flossing to progress the treatment of the neurodynamic component. Obviously, you're going to always reassess your objective exam asterisk after treatment to monitor the effectiveness of your treatment choice. If the treatment is not effective, then progress to treatment of neurodynamic components. So what I'm saying here is that when you're treating the joint signs and the soft tissue signs and you are reassessing your neural dynamic test and that's not improving or improvement has plateaued, then progress to adding in the nerve sliders. So nerve sliders is the process of lengthening the nerve bed at one end of the nerve and shortening the nerve bed at the other end. There's an associated with increased longitudinal translation of the nerve. And so there's an example where you can side bend towards the area of pain while you're extending the elbow and wrist, and then side bend away while you flex the elbow and wrist. That's an example of a nerve slider. The nerve tensioners is another route to go with neural flossing, and this is a process of lengthening or stretching the nerve bed at one or both ends of the nerve bed. So this is associated with increasing and decreasing pressure inside the nerve, as well as potential benefits for increasing the mobility, not necessarily nerve length, but the mobility. So an example of that would be to side bend away while extending the elbow and wrist, and then to side bend your neck towards while you flex the elbow and wrist. So some final considerations for severe and irritable disorder. Patient must be relaxed and comfortable. Do not start treatment using the neurodynamic test position. Initially, the mobilizing tension technique should not be provoking. Begin with a mobilizing tension technique removed from the symptomatic area. And considerations for a severe irritable disorder, again, oscillatory techniques are used as opposed to sustaining techniques. Slow rhythmic oscillations, 15 to 60 seconds, and then you can progress from there. And then considerations for a non-severe, non-irritable patient are to initially use techniques that will be going into some resistance. The bouts are longer, the duration is longer, and the technique can be started in a longer position and can be performed with other components in different positions closer to the area of symptoms.